Ladies and gentlemen, thank you for standing by. Welcome to today's program entitled Chronic Graft versus Host Disease Webinar, Improving Life for Patients with cGVHD, with a focus on lung issues, psychosocial support, a person's perspective, and more. At this time, all participants are in listen-only mode. There will be a question and answer session following the formal presentation. You may ask a question at any time by typing it into the Ask a Question feature on your screen. It's now my pleasure to turn the call over to Jennifer Gillette. Please go ahead, Jen.
Thank you. Thanks so much, Kevin, for helping us host this, and thank you everyone for being here today. We are so pleased to bring you this chronic graft versus host disease webinar, and we know that there's so many people that really need this information. So thank you for being here. Just a little outline for today. I'm going to do a brief introduction to the National Bone Marrow Transplant Link, and then we'll have Dr. Yanik speaking for about 20 minutes. Then we will have Lauren Saban speaking for about 20 minutes, and then Becky Dame for about 20 minutes, and then we'll have about approximately a half hour for questions. Also, just because I know this comes up with most webinars we do have printouts that will be downloaded on our website so that you can have access to those slides, and you can also listen to this at a later date. I also want to let everyone know you're going to be receiving a survey today. This helps us improve our programs for you, as well as gives you a voice for future programming. So I encourage you, if you have a second, to fill that out. So now on to information about the National Bone Marrow Transplant Link. Our mission is dedicated to helping individuals and their families from diagnosis through survivorship. We work with hospitals, cancer centers, and other organizations to reinforce and complement medical care by providing resources, support, and education. We link you to experts across the country and all kinds of topics related to transplant and to others who have made it through this journey before you. There is our contact information on the right, and if anyone needs extra support today, I encourage you to reach out. Some of the resources we have are these Lunch and Learn programs, podcasts, webinars. We have blogs from people who have been through what you are going through on our website, as well as we have an active social media Facebook page and an Instagram page to provide daily inspiration. We also have our peer support program if you want to talk to other patients or caregivers who have been through the journey. We have our second birthdays recognition program, because once you've had a transplant, you get two birthdays, and I recommend you celebrate them. We also have some amazing books that we have a picture of here, and if you're interested in any of them, you can reach out to us and we'll gladly send you one. And if ever you need to talk to a social worker or get some referrals, you are welcome to give us a call as well. We'd like to have a special thank you to our webinar event sponsor, Pharmacyclics and Insight, and of course our esteemed link partners for all their continued support. We could not do our programs without this support. Just as a reminder, today's presentation is meant to inform and support. It is not intended to replace any of your individualized medical plan. So now a little more information about our speakers. Dr. Gregory Yanik. He is a clinical professor, a specialty of pediatric hematology oncology, pediatrics, internal medicine, treatment of acute lung injury post-transplant, and is part of the Pediatric Bone Marrow Transplant Clinic at C.S. Mott Children's Hospital. He has been a faculty member within the Blood and Marrow Transplant Program and the Division of the University of Michigan since 1992. He was born and raised in the Detroit area, attended medical school at Wayne State University, and trained in hematology oncology at Cincinnati Children's Hospital. He and his wife, Mary Beth, have 3 grown children, and he has been the recipient of many prestigious awards in recognition of his contributions to medical research, clinical care, education, including the Leland and Elaine Black Professorship of Pediatric Oncology, the University of Michigan Pediatric Teacher of the Year Award, and the Leukemia Lymphoma Society Chairman's Citation for Outstanding Service. Dr. Yanik is the founder and chair of the Executive Committee for the Children's Hematology Alliance of Michigan and a unique alliance of pediatric hematology practice teams in the state of Michigan, whose goal is to continuously improve the quality of care for children with these medical conditions, regardless of where they are treated in the state. In addition to these many activities, Dr. Yanik makes time to serve on the Executive Committee for Make-A-Wish Michigan. And then we have Lauren Saban, who is an LCSW from Memorial Sloan Kettering Cancer Center. She's a clinical social worker, and she graduated from NYU Silver School of Social Work in May 2019. She joined MSKCC in December 2019, and she has a special training in trauma-informed child and adolescent care from the National Institute for Psychotherapy. She has more than 3.5 years of experience supporting patients, caregivers, and families cared for by both the inpatient and outpatient adult bone marrow transplant and cell therapy services at Memorial Sloan Kettering. And then we have Becky Dame, who is an RN and also a survivor and an information specialist for the Leukemia Lymphoma Society. Becky was diagnosed as a college student in 1991 and received her first bone marrow transplant in 1992. At this time, she felt called to be a nurse and changed from a music major to nursing school, marrying her husband on the day she graduated. For 18 years, she went through the cycles of relapse, always on the lookout for the newest treatments for her disease. And then in 2010, she received a matched unrelated donor transplant and was able to break that cycle. Today, however, Becky battles graft versus host disease. In 2017, she joined the Leukemia Lymphoma Society, where she says it's her goal to share her pearls of wisdom with patients, caregivers, and anyone else that she can find commonalities with. On that note, I'm going to hand it over to Dr. Yanik, but as you can all tell, you are in good hands with people with a lot of wisdom to share. So thank you all for being here.
Thank you, Jennifer. It's really a pleasure to be here, everyone. Can you see the slides well? Good.
You can see the slides. On my end, if there's any way you can maybe speak just a smidge louder, but I see the slides.
Sounds good. I'll lean over the phone.
All right. Thank you.
No, it truly is a pleasure to be here talking with everyone, and I appreciate the kind introduction. As Jennifer said, I'm for the University of Michigan Medical Center. You know, this quote at the bottom of this first slide actually says a lot, not just about transplant and going through the transplant process, but it says a lot about life. This is almost 100-year-old quote, and I really feel the last part of it, that the real purpose and path to health and healing is to make joyful connections. And I'm honored to be making a joyful connection with everybody here from NBT Link and all of you listening today. In fact, when I think about lung GVH, I've had a particular research interest in lung GVH for the past 30 years. I view it as the hidden form of GVH. You can feel it, but you can't see it because it's deep in the lungs. One of my colleagues, in fact, you'll hear me reference her several times during this talk. Her name is Guangxing Cheng in Seattle at the Fred Hutchinson Cancer Research Center. She held a lung symposia, I guess, for patients with lung GVH, and she sent me some of the quotes from those that had lung GVH that were at this forum that she had. And you can just read through them. I need to breathe to live, but I also need to live to breathe. I'm alive, but I've had so much loss. If I had known I would get lung disease like this, I would have rather died from an AML. For any of you listening that have had lung GVH, my heart goes out to you, because it is the hidden form of GVH. You may look fine on the outside. You know deep down on the inside, it's tough to get upstairs. It's tough to get downstairs. It's tough to go out for walks in the cold. It's just tough to live. So today, I want to just walk you through what lung GVH is and hopefully give you some hope. How do we define lung GVH? Well, for those of you listening, it's the lung manifestation of chronic GVH, so it's chronic GVH of the lungs. What we think of it as an obstructive airway disease. It occurs typically about a year out from transplant, and the way I like to think of it is that air can get in, but it can't get back out. The air, it's almost like a balloon where you've got the neck of the balloon pinched, and the air, instead of coming out quick, it just comes out much slower than normal. The pinching of the neck of the balloon is scar tissue that forms around that neck. The air you breathe gets trapped, and then the air gets stagnant in your lungs. As the air gets stagnant, then you start picking up infections too. The symptoms are pretty standard: shortness of breath, chronic cough, fatigue. You just don't feel like doing anything when you've got GVH in the lungs. It occurs, how often does it occur? It occurs in about 10 to 20% of all patients who have chronic GVH. Fortunately, not 80% of patients who get chronic GVH don't get it in the lungs, but those who do definitely will remember it. The medical term, you'll hear physicians use the term bronchiolitis obliterans syndrome. I'll actually show you what that means in English today. So where does lung GVH occur? On this slide here, you can see time going out on the x-axis. Acute GVH typically occurs in the first 50, 100, 200 days after transplant in green. Chronic GVH typically peaks around a year out. That's also the time that we start seeing lung GVH. The onset is typically about a year out from transplant in most patients. So fortunately for lung GVH, we've learned a lot in the past decade. There's certainly a lot of new diagnostic techniques for picking it up, and I'll show you some of them today. A lot of collaborative medical teams doing research in this have now formed across the country. We've got a number of tests that we can do that can help predict early on who can get GVH in the lungs. There have been a number of novel clinical trials out there for patients with it. And just as much, the support from the community, the philanthropic support, has been tremendous for researchers over the past decade. So what I thought I would do is give you insight into things that you don't normally see. So this slide is a primer, pathology of lung GVH. You'll see three boxes here. The box on the left are normal lungs, and then as you go out to the right, you'll start seeing abnormal lungs with lung GVH. As you look at the left box, this is actually what we would see if we looked under a microscope slide of somebody's lungs. The big white space there is an air sac. That's where air gets transported from your lungs into your bloodstream. And this circle right here, this is a small airway. It's called a bronchiole. As you see, as lung GVH starts developing, that tube, that bronchiole, gets thicker. It eventually gets so thick that the air gets blocked. Air can get in because you can forcibly get it in, but it's hard to get out. It's that pinching of the neck of the balloon. And that's the term that we as physicians use, bronchiolitis obliterans syndrome. Itis refers to inflammation of the bronchioles, the small airways. Obliterans meaning that eventually they get obliterated. Who gets it? We did a large study at the University of Michigan, over 1,000 patients, looking at them. Here's who we saw had the highest risk of getting GVH in the lungs. One, patients who had high-grade or severe acute GVH, meaning not GVH in the chronic form, but a severe acute GVH that had occurred 3, 6, 9 months earlier. Two, this one in particular, the second bullet point, patients who develop infections in their lungs, viral infections or pneumonia within the first 3 months after transplant, that lung infection tended to set off this low-level inflammation that eventually led to this GVH in the lungs 6, 12 months later. And then three, patients who had very low PFT values. That term PFT, it refers to pulmonary function tests, either prior to transplant or about 3 months after transplant, were the ones that would then go on to get the GVH in the lungs a year after transplant. So PFTs, I'll have to walk you through what all this means, and I'll show you a few slides on this. So how is lung GVHD diagnosed? This is actually the NIH criteria that we as physicians use for diagnosing lung GVH in patients. It requires PFTs or pulmonary function testing. The main criteria is this: an FEV1 less than 75% of normal for someone's age and size. And it must have declined from 10% from prior to transplant. I guess that you could ask, looking at the slide, what does this all mean to patients in English? What does even an FEV1 mean? But this is the criteria that we as physicians use. You can now start talking our language after watching this talk. Hopefully many of you that have gone through transplant or have had chronic graft-versus-host disease have underwent the pulmonary function test. As patients tell me, it's like, and I've done it just to see what it's like blowing your brains out. You just have to take a deep breath and exhale, 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 as one patient said. I thought I was going to die during the test, just as I had to breathe out so long and so hard. So I said on 2 slides ago that the main parameter that we as physicians look at to diagnose lung GVH is FEV1. Here's what FEV1 means. It means forced expiratory volume in 1 second. It's the amount of air that you can actually exhale forcibly in 1 second. Here's what we see as physicians. We'll see this. Tidal volume. That's your normal breathing. All of us right now listening to this talk, we breathe in, we breathe out. It's just this wave up and down. When you do PFTs, we actually take a deep breath and you exhale as hard and as long as you can. And that's the FEV1. How much air can you actually exhale in 1 second? If you think about the slide I showed 2 slides ago, we want it to be over 75%, preferably 90, 100%. Well, the key is, and why PFTs are so important, is the next slide. If you're going to remember any take-home slide, and the one that you may groan on looking at, it's this next slide coming up. It behooves us as physicians to make the diagnosis of GVH of the lungs in its early form. When that FEV1, we make the diagnosis again when that FEV1 is less than 75%. So the green line here shows the survival for patients if we made the diagnosis when that FEV1 was 60 to 75%. The blue line here shows the survival for patients, survival over OS means overall survival in years. If we made the diagnosis when their FEV1 had already dropped down to 40 to 60% of normal. And then the red line shows the survival for patients at our center, and this is pretty typical for most centers, if the diagnosis is made when their FEV1 is already less than 40%. Meaning if you're going to get lung GVH, get it diagnosed while you're still on the green line, while we have a chance to reverse it. If it's not diagnosed till it's already in the red, then you're already running into problems. So at our center, and at many centers, the average time, so the median is basically the average FEV1 at the time we diagnose lung GVH, is already in the blue line, 57%. I've talked to a number of physicians at other centers, they see the same thing. The average time to diagnosing patients are already on the blue line. And that's the key. The problem is that we start treating here, way out on the right-hand side, when those airways are already thickened. We need to start treating here, and we need to be recognizing who at risk right here when the lungs are still normal. And that's where we need to go from a physician and research standpoint. Again, my colleague, Dr. Guangxing Ching in Seattle, she held this forum, and then she had a 54-patient survey that was administered. And one of the questions she asked was, what aspects of BOS, again, that's lung GVH, and lung complications after transplant should researchers focus on? You can see here in orange, the number one factor or aspect that patients felt should be early diagnosis and prevention. And that was actually a really wise choice, because the earlier we can diagnose the lung GVH, the better chance we have of reversing it and treating it. If we wait to treat it until the lungs are already scarred down, it's very difficult to turn around. We have to catch it early. So the key is, I always like to quote any talk that uses a quote from Woody Allen, I figure is a good way to go. So 85% of success is just showing up, meaning just get PFTs. If we can get PFTs, then we have a chance of catching your lung GVH before it's too late. And that behooves us as physicians to also then teach you as patients. How often should pulmonary function tests be done? There's actually established criteria. And for everybody who's had a transplant, ask yourself, are you meeting these criteria? So these criteria put out by the NIH in 2020, what's recommended is the following, that PFTs should be obtained every 3 months in the first year after transplant. Ask yourself, did you have PFTs performed in the first 3 months after transplant? That's the NIH recommendation. And once you get chronic GVH, the PFT should continue to be performed every 3 months. If you've got chronic GVH, ask yourself, are you getting PFTs done every 3 months right now? Are there alternatives to obtaining the regular PFTs? PFTs are tough for patients to go through. It's just so hard to take these deep breaths and breathe out if you've had it. Just so hard to do. So are there any alternatives? Well, again, I'll go back to my colleague in Seattle. She and I are close collaborators and friends. She's actually developed a PFT testing in your own hands. It's an NIH-funded study. Patients have a home PFT device. You can see it in the bottom right-hand picture there. It fits in the palm of your hand. Right now we have our patients doing this, using this device weekly. You could do it every day if you wanted to. You could do it every hour if you wanted to. The beauty of this device is that it syncs up with an iPhone, your iPhone, so you can see your own PFT readings. It also syncs up with our databases so that we get it in real time. We can see your PFTs. In fact, we see it so quickly that if we see a sudden drop, we'll start talking to your transplant physicians immediately, saying, hey, Jim Jones, Julie Smith just had a 10% drop in their lung function on their handheld spirometry. Get them into clinic quick so that we can start treating their GVH in the lungs. So this is a thing of beauty, this device. I would ask you to start talking to your physicians around the country to see if they have this handheld spirometry available. There's also a new CAT scan technique. CAT scans is a way of looking at the lungs really closely. But if you look at CAT scans, you can only see so much. They're in this black and white scale. We actually developed at the University of Michigan this color-coded CAT scan technique. And we can actually take your normal CAT scan and color-code it to see how severe the GVH is. By the way, the color codes here, anything in green is normal lungs. Anything in yellow is where the GVH is forming. Anything in red or purple is where you're starting to get pretty significant scar tissue. This patient here came to our center. We did this CAT scan. His PFTs and his regular CAT scan were both read as normal. Yet when we did this imaging called PRM and color-coded it, you could see that really only about half of his lungs were green, even though his PFTs were still read as normal. Here's 2 years after transplant. At this time, the PFTs were now under that 75% limit, and you could see it right there. He already had a lot of yellow, though, and not a lot of green left. And then by this year, 5 years after transplant, you can see there's starting to be a lot of red involved, and lungs are pretty much all yellow. The key for us is to diagnose this when there's mostly green and very little yellow, and that's when we want to treat. Therapy for lung GVH, there's been, sadly enough, few randomized clinical trials done, not only in the U.S. but around the country, and most of the trials have only involved 20 to 30 patients, so small trials. 2 trials that have impacted care, maybe they've even impacted your care if you have lung GVH. One was by a study from Anne Bergeron in Paris using these steroid inhalers that many of you may use, fluticasone and some of the other steroid inhalers. And then my good friend Kirsten Williams, right now at Emory, she was the one who pioneered the use of what's called FAM therapy. FAM therapy, the F is for inhaled fluticasone, the A is for an antibiotic called azithromycin that actually works as an anti-inflammatory agent on the lungs. And the M stands for a drug called montelukast. It's taken orally. It's also called Singulair, which acts as an anti-inflammatory agent on the lungs. These 2 trials right here, both positive trials, have really impacted how we treat patients who get lung GVH. But there are other trials out there. If you look at it, I'll just quickly walk you through them. These are the trials. There's 1, 2, 3, 4, 5, 6, 7 trials right now on clinicaltrials.gov using pretty novel drugs for treating lung GVH. If you start from the upper right-hand side, the first picture where it says Avelostat is being run at the NIH by a friend named Steve Pavletich. Amin Alusi at MD Anderson in Houston is using a drug called edasitinib. Joe Su in Stanford is using a drug that breaks down scar tissue called pirfenidone. Liposomal, this is inhaled cyclosporin, is being used by a group in Europe. Then you've got another drug called nintedanib, which breaks down scar tissue. You've got a strong anti-inflammatory drug called ruxolitinib or Jakafi that's being run by 2 separate studies, one at Mass General and one in Cincinnati. And then the team in Boston by Corey Cutler is using a drug called belumosudil. It's another drug that blocks the formation of fibrosis in the lungs. So I'm hoping that one or more of these trials will give hope for patients who have lung GVH. I just want to end with 2 slides. It's this, the power of exercise. And I can't stress this enough, how much exercise can actually help patients who get lung GVH. On the left-hand side, you'll actually see our medical PFT report from a patient. This is a 50-year-old male at our center that had chronic GVH. This is what we as physicians see. And in red, you'll see that thing called FEV1. I said lung GVH is present when it's under 75%. Well, this patient, his first initial is T, so T's FEV1 was 52%. It's this next line. I didn't tell you what this is, but you'll see this on your PFTs. Ask your physician for this one. It says DLCO. What DLCO refers to is the ability for air to be transported from your lungs into your bloodstream. So if you can see here, T's ability for air, the air that he breathed to get into his bloodstream is 107%. So I went back and said, this is amazing PFTs, T. I haven't seen it like this. He said, well, Dr. Yanik, about 5-6 years ago, after I got GVH of the lungs, I started bike riding. I now bike ride 30 miles a day. In the winter, I use my Peloton downstairs. I went back and looked at his PFTs at the start of his lung GVH. You could see that that DLCO was 77%. With 5 years of bike riding, he got his DLCO up to 107%. The FEV1 never changed. It's still in the 50%. He still has the scar tissue in the lungs. But every single oxygen molecule he inhales gets transported across the lungs into the blood vessels. So with exercise, he actually improved his ability. He didn't break down scar tissue, but improved his ability to get air that he does breathe in into the blood vessels. And this has been key for him. He's actually continuing to do well just because of this, and thus the power of exercise. And I'm going to end with these last two slides. This comes from a great book. If you've ever seen this book, you'll love it. The Boy, the Mole, the Fox, and the Horse. The quote at the top, this is one of the pages in the book. What is the bravest thing you've ever said? Asked the boy to the horse. And the horse's reply, help. But it's a circle of help. You as patients are looking to us as clinicians, transplant physicians, for help. Us as transplant physicians are looking to researchers to help us develop new technology. And the researchers are looking to you as patients to help be involved in these clinical trials. It's a circle of help, and it's a circle of gratitude. And that's where we are. And thus, I'd like to thank everyone. I'd like to thank the NBMT link, also the patients we serve, to all of you out there listening, and to the medical teams I work with, and again, to all of you. By the way, that picture on the far right is not a transplant patient. That's my little granddaughter and my son. I figure any talk I can show a picture of her is a good talk for me. Thank you.
Oh my goodness, she's cute as a button, Dr. Yanik. Love the slide, and thank you for a wonderful presentation with so much compassion and explaining it in a way that's easy for us to understand. Thank you so much. And now I would like to introduce Lauren Saban. Thanks for being with us.
Thank you, Jennifer. Thank you for having me. And thank you, Dr. Yanik, for a really great and thorough presentation on lung GVHD. We heard Dr. Yanik speak about GVHD as it affects the lungs. However, GVHD can show up in many parts of the body, either in an acute or in a chronic setting. For the purposes of this presentation, we'll focus more on what it's like for patients who are experiencing chronic GVHD. GVHD can show up in many different ways and can impact the body in a lot of different ways too. In supporting patients with GVHD, we'll often see a high symptom burden, which often leads to a need for a lot of close follow-up with the interdisciplinary team. The symptoms of GVHD can fluctuate from patient to patient and also within one patient's experience, ranging from mild and manageable to severe and life-threatening. It's important for us to also pay attention to the ways that the symptoms of GVHD can be compounded by some of the more common post-transplant side effects, most notably fatigue. Many patients hope and assume that they'll return to normal by day 100 or 1 year post-transplant, so it's usually difficult to adjust when symptoms of transplant and chronic GVHD are still prevalent far out from their transplant. Chronic GVHD doesn't happen in a vacuum. So when we think about the physical impact, it's important for us to pay attention to the multifaceted ways that this shows up for our patients too. Throughout the transplant process, we'll often see how one's identity and sense of self becomes medicalized. In many ways, they're tethered to the medical team. Our patients and their caregivers are existing in a space where their previous identity is suspended or put on hold. For those managing chronic GVHD, we'll often see frequent outpatient follow-up beyond day 100, which is usually when we would hope to see less frequent medical appointments. And with that can also come a high medication burden, especially when we take into consideration the often needed steroids for management of symptoms. It's also important to note the other supportive services that patients may need as part of that interdisciplinary team, including physical therapy, occupational therapy, meeting with clinical dietitians, or supportive care for better pain management. During this time, where their lives are in many respects put on hold, we often see a need for continued caregiver support and a need to stay near the medical center longer than originally anticipated. We'll often see an inability to return to work at the same capacity, if at all, which can often lead to acute financial distress. One of the harder things to grapple with is the constant and consistent reminder of one's diagnosis, transplant, or mortality due to this ever-present symptoms or high medication burden. And this existential distress can be quite apparent and difficult to cope with. Something that I've seen in my work all too often is patients who will not die of their cancer or disease, but rather from complications of transplant, such as chronic GVHD. It can be quite unimaginable for friends and families to process this when it happens, and it's especially difficult when transplant may be proposed as a cure. I'll often say with patients and caregivers that when the body doesn't feel good, the mind usually follows. I think this speaks to the psychological distress that we'll often see with patients and caregivers who are dealing with and managing chronic GVHD. I'll often note the profound changes in one's emotional well-being, their self-esteem, and their resilience as they're navigating the trajectory of transplant, which includes chronic GVHD. We'll often see anxiety present itself in a multitude of ways, including feelings of restlessness and a general sense of unease. A lot of the time, the sense of anxiety stems from the unknown, not knowing what to expect, whether the transplant itself will be successful, and whether they will have relief from their symptoms of chronic GVHD. As an oncology social worker working primarily with transplant and cell therapy patients, I often work a lot around their profound and acute feelings of hopelessness, struggling to maintain hope that they will feel better, that they'll regain a sense of self, or that they'll be cured. As patients and caregivers move farther and farther away from day zero, through their early bone marrow biopsies, past the first 100 days, and into survivorship, they'll often report a pervasive and consistent fear of pain and relapse. With this ever-present sense of fear, many will also face feelings of depression. This has been shown in many studies of this population, including the one here listed on the left. This was done by Jacobs et al. In 2019, and it indicated clinically significant anxiety and depression at multiple points in time for those who are post-transplant and dealing with chronic GVHD. Another piece to note that I think is a bit more prevalent when dealing with chronic GVHD patients are psychological symptoms related to post-traumatic stress. This can show up in a lot of ways. For example, hypervigilance, increased social isolation, agitation, loss of interest in activities that may have once brought joy, difficulty sleeping, and intrusive thoughts. Most importantly, I've witnessed immense resilience in this population. Chronic GVHD can be extremely difficult to live with, but time and time again, I get to interact with people who are willing to do whatever it takes to continue living, even with sometimes unbearable symptoms. For me, this is the piece that I pay close attention to: their values as a person, what motivates them, and what will provide them with the greatest quality of life. With these profound changes and difficult symptoms, patients and caregivers may often feel a sense of loss. Ambiguous loss, referring to a type of loss that lacks closure or clarity, helps to provide a framework for understanding one's experience through transplant, and especially so when managing chronic GVHD. Ambiguous loss is an interesting concept that allows us to name losses that aren't as concrete as a physical death, but are losses that are experienced nonetheless. Both within and outside of transplant, this can look like the loss of ability or functional status, loss of body parts, of pets, of roles, such as with divorce, separation, or estrangement, missing persons, and a loss of expectations and hope for the future. I really appreciate Dr. Yanik's quote early on in his slide from a patient living with GVHD, where they said, "I'm alive, but I've had so much loss." A couple of examples from my work include a widow and a mother of 2 children who lost her idea of retirement, as most of her time is now spent in and out of the hospital to manage severe skin GVHD, and a survivor of 3 allogeneic transplants who fought hard to live for a future with her children, only to die from grade 4 GI GVHD without any evidence of leukemia. I actually read something recently that really helped to concretize this idea. It was an article written by someone reflecting on the cancer journey of their sister, and in it she writes, "Cancer stole so much from her. Her past, because her life would be overshadowed by the way it ended. Her present, because of the 2.5 years she had it, there was never a moment's peace nor comfort. Most of all, her future, which she will never get. The career she had in mind, the work left unfinished." For me, this really helped to exemplify the way that non-tangible losses can feel as real as a concrete loss, like the loss of someone when they die. Patients may experience many layers of ambiguous loss. They're here, but no longer as they once were. Caregivers, too, may experience a sense of loss, even though their loved one is still physically present. They're losing the way they used to know their loved one. When we think about loss, we think about grief as a way to process and integrate these experiences. Disenfranchised grief, referring to grief that is not openly acknowledged, mourned, or socially supported, speaks to the emotional toll that chronic GVHD places on patients and caregivers, which can often result in grief that is unnamed or invalidated. Patients and caregivers should be provided with the space to grieve these ambiguous losses, the lives that they had before, which can sometimes not feel like a valid loss, especially in the context of transplant as a cure. This can lead to an increased sense of isolation in one's grief. For many, this can look like a deep misunderstanding of their situation by friends, family, and coworkers, with many not truly able to understand that living without cancer doesn't always mean living without high medical needs, symptoms, or a burden. In my work as a transplant social worker for almost 4 years now, I found that my most important role is providing emotional support to help patients and caregivers process these experiences and integrate them into their lives moving forward. A lot of what I do is providing space to hear about their experiences, and with that, listening, empathically and actively. I work to validate their experiences and what they're feeling and normalize it, helping them to understand that they're not alone in this experience and that many others feel the way that they do too. And especially so providing psychoeducation based on research and my own experiences. It's important to maintain a trauma-informed approach, which can be extremely difficult in the inpatient setting. In that setting too, I take part of goals of care meetings with one's family and the interdisciplinary team. And I think that this helps to ensure that we're truly paying attention to the person who's impacted by this. A big part of my role is also ensuring access to hospital and community resources. These resources can be for individual support and psychoeducation with oncology social workers, psychologists, or psychiatrists who may specialize in working with patients with cancer or chronic illnesses. Within MSK, where I have been for the last 4 years, this would be connecting them to their outpatient social worker or to our counseling center once they're discharged. The NMDP has a program that supports patients and caregivers by providing one-on-one emotional support too. For many dealing with chronic GVHD, they might feel isolated in these experiences, and so it's important to connect them to specialized support groups facilitated by appropriate support staff. At MSK, we currently have a monthly post-transplant online group for young adults, and the NMDP has terrific BMT survivorship chats. One of the things that I have found to be most helpful is also connecting patients and caregivers to peers who understand better what they are experiencing. NBMT Link has their peer support on-call program, and the Leukemia Lymphoma Society has the Patty Robinson-Kaufman First Connection program. Now, this list is not intended to be complete because there are so many other resources in the community that can support patients and caregivers as they're navigating this experience. And so it's really important to connect them to these resources so that they can have ample support throughout the trajectory of their care. And here are just some references from the slides previous. And I want to thank all of you for joining today and the NBMT Link for asking me to be part of this presentation. It's terrific to get to connect with others who are in this field and to provide just a little bit of education around what I do as an oncology social worker here at MSK.
Thank you so much, Lauren. We appreciate you being here and sharing some of the ways that you try to help people through this process. Thank you very much. And now we will hear from Becky Dame. Thank you for being with us, Becky.
Thank you very much, and good afternoon or morning. It's a pleasure to be with you today. I first want to thank the National BMT Link for putting on webinars like this for people like you and me. I'm humbled to be following Dr. Yanik and Lauren, who brought both the medical and social aspects of this disease. I bring a slightly different perspective today, and that's as a patient, a survivor, and a nurse. My story can be long, so I will try a condensed version. 32 years ago, after 2 weeks into my freshman year of college, I would be diagnosed with chronic myeloid leukemia, known as CML. As an 18-year-old, I didn't even know for sure what it was, but due to my faith, I told God that I was okay with whatever He had for me as long as it changed one person's life. So in 1991, the only curative treatment for CML was to have a bone marrow transplant, now more commonly referred to as a stem cell transplant. My sister would be a perfect match, and I received my first transplant in January 1992 at St. Jude Children's Research Hospital. So there's a lot of history here between the pictures shown. This is a picture of me and Ben. Ben was my admitting nurse. He obviously made a huge impact on me, and we would meet each other on my follow-up appointments. On my last follow-up appointment, he had finally retired. We still made a point to see each other. So my first transplant was truly brutal, but it was successful. I did not experience any graft versus host disease. So I felt very blessed and decided to give back by becoming a nurse. During my last semester of nursing school, I would have my 3-year follow-up evaluation and find out that my leukemia was back. So let's chat a minute about the process of graft versus host disease. I'm sure Dr. Yanik reviewed some of this in his slides, but a super simple explanation of graft versus host is when your donor cells, the T cells, attack your body because it doesn't recognize it as itself. So when your donor doesn't recognize your skin or your lungs, it would also not recognize any of your old stem cells that would have leukemia and attack it. And this is called GVL, graft versus leukemia. So graft versus host is known as a double-edged sword. A little is good, and a lot can be bad. It's a balancing act of either just enough, but not too much graft versus host disease, while still allowing for the process of GVL to keep your disease in a state of remission. I would literally receive more donor cells that would cause graft versus host, but also without any additional medications, the process of graft versus leukemia would destroy my leukemia, putting me back into remission time and time again. Again, my journey was very long, and ultimately, after my 6th relapse, we decided to try a new donor. I would have a second transplant 18 years after my first in September of 2010. My second transplant was done at the Moffitt Cancer Center in Tampa, which is where I also worked as a transplant nurse coordinator. So this time my transplant was an unrelated donor, a 10 of 10 match. The transplant would go well, excuse me, and I would experience acute graft versus host disease and continue to live on with chronic GVHD. But I have been in remission now and cancer-free for 13 years. So one of my very favorite pictures is the picture shown here. It was my first day out of the hospital after my second transplant with my little doggy, Gracie. So most of you have seen a list like this before. These are the most common chronic GVHD symptoms. The ones in red are the ones I've personally experienced over my past 32 years. These can occur at any time post-transplant. What I think most patients and caregivers fail to realize is that I said any time. Graft versus host disease is not just something you watch for in the first and second year out of transplant. It is a potentially a lifelong issue that you must be diligent to watch for. My personal philosophy is to assume any new symptoms are GVHD until it's ruled out. Never sit on your symptoms. It is easy to put out a couple of embers, but not a forest fire. So here is a 1-year snapshot for you. So before the first picture here in December of 2004, I was receiving what they call donor lymphocyte infusions, meaning more T cells from my donor because my leukemia had returned. I was on no medications. I woke up that morning and my hair was falling out in clumps. I had chronic GVHD alopecia, meaning hair loss. We would start on steroids, and by February, I had experienced 90% hair loss and would begin to have puffy cheeks. And by June, I look in a mirror and not recognize the bald, badly swollen girl with 3 chins. But also at that time, my GVHD was controlled, and I was able to taper off steroids and go back on maintenance medications. And by December 2005, my hair was growing back, and I was beginning to look like myself again. I believe today's chronic graft-versus-host disease focus is on graft-versus-host disease of the lungs. I have had graft-versus-host disease of the lungs in the past, and actually my last flare was just 2 years ago. Actually, 2 years ago today, I was in the hospital with chronic GVHD of the lungs and liver. Of course, I experienced all the typical tests and procedures, including CAT scans, extensive lab work to rule out problems and infections, a bronchoscopy, IV antibiotics, and even required oxygen therapy. Prior to this, I was on 4 maintenance graft-versus-host disease medications, but this flare would break through them all. So the doctors pulled out the big guns, and I was placed on high-dose steroids once again to put the fire out. Once the fire was controlled, I was able to taper off steroids again and go back on maintenance medication. I say all this to say I'm blessed. We never know what God has in store for us, and it's only by His grace I'm speaking with you today. And now I am certain that He's changed at least one person's life by hearing my story today. So thank you for your time and attention, and just know that be your best advocate. Thank you so much.
Becky, thank you so much for being here. You are an amazing human being, and anytime I've heard you speak, I am just totally inspired by you. I am so honored to work at MBMT Link because I meet amazing people like you all. So thank you so much. At this time, Kevin, can you remind everyone how to ask questions today?
Certainly. You may ask a question at any time by typing it into the Ask a Question feature on your screen. Once again, you may ask a question anytime by typing it into the Ask a Question feature on your screen.
Thank you, Kevin. I'm going to start. Dr. Yanik, it looks like we're getting some medical-based ones, and I'll start with you with some of these answers. One writer says, my son had severe case of chronic graft-versus-host disease, and it seems to have gone away. Can everyone hear me okay?
Yes.
Oh, I'm sorry. I saw something in the chat. Anyway, so my son had a severe case of chronic graft-versus-host disease, and it seems to have gone away. How likely is it to return?
You know, it's a great question. It depends on several factors. One, if your son is still on drugs that would suppress his immune system, what happens as you cut those drugs down? We call it taper them down. I always view GVH like a fire. So as you view the therapy for GVH like throwing water on the fire. So as we start throwing less water on the fire, those fires come back. That's part of the problem we have with physicians, is that oftentimes we get down to simmering embers, and we can't tell that. We don't have a blood test that tells us that there's still simmering embers. We have to just watch closely and see. And that's why getting the pulmonary function test every 3 months, that's why having regimented exams with your physician every couple months, depending on how far out from transplant you are key, that we can pick up if the GVH comes back. So to make a short answer long, there is a chance that if your son is on drugs that suppress his immune system, and as the physicians start cutting those drugs back, I'll give you my own personal experience, it's probably a 50-50 chance that the GVH will come back. On the other hand, if a patient is off immune suppressant drugs, it's already been a year or more since they last had any signs of any GVH flare, then chances are that fire is burnt out, there's no more simmering embers, and that it's unlikely to come back. So really, to answer the question, it just depends on where a patient is in their treatment. If they're being tapered down on their treatment, then be diligent and watch close, because I'd say it's a 50-50 chance they could flare back up, that fire could come back up as you taper down the drugs. If you're already off the drugs and it's been a year or more, to be honest with you, it's highly unlikely that it could come back. It's more likely burnt out. So hope that helps.
Absolutely. Thank you. One of our buddies here also writes, how is that related to ILD? I was diagnosed with that. My pulmonologist said my lungs are at 30%, however, are not getting worse. He showed me a graph with a straight line of not getting worse. So, thoughts on that, Dr. Yanik?
Yes. I would actually like to ask the person who's asking the question, how far out from transplant are they? If they could just type that back in. There's 2 forms of ILD.
We will get that shortly. I know he's been out of transplant for a while, but I am trying to remember, because he was diagnosed on 9/11, but I'm trying to remember when his actual transplant was. But we'll see if we can get an answer there.
Well, that helps, Jennifer, though. So basically, with ILD, there's 2 forms of ILD. There's ILD that occurs acutely in the first month or 2 after transplant. Typically, that's treated with steroids and some other drugs that we use. And then there's an ILD that can occur just like the GVH that I talked about. It can occur about a year out from transplant. So I always view GVH of the lungs this way, to everybody listening. If the scar tissue is forming around the tubes, the airways, the bronchioles, then it pinches those airways and you get obstruction of airflow. Air can't get back out. Air gets trapped. That's the standard GVH of the lungs. However, if the scar tissue forms in the lung tissue itself and not around the airways, then the lungs get tighter. If that happens, then it's going to look like ILD, interstitial lung disease. So ILD, for everybody listening, stands for interstitial lung disease. Basically, you can think of it as tight lungs. And it's where the lung, you can't even get the air in half the time. Whereas BOS that I referred to in my talk, where you can get the air in, you just can't get it out. I guess to make a short answer long, there's two forms of GVH of the lungs. The one I focused on is where airflow gets blocked. It can get in but can't get out. But then there's a type that this gentleman refers to called ILD, where the lungs just get tight. We treat both similarly, though ultimately they may be different from a pathology standpoint.
Okay, thank you. Another medical question here. What are the treatments for lungs that have steroid-induced myopathy?
So I would like to, it'd be nice if I could talk to the person asking the question. Does that mean that the myopathy is affecting the lungs and the ability to breathe, or the myopathy meaning that you've been on steroids for lung GVH and now it's weakened your muscles? If it's the latter, if it's the second part, where you've been on steroids to treat lung GVH and now your muscles are so weak from the steroids, then what we do as physicians is we get the patients down and off of oral steroids. We have them on inhaled steroids, and we add on. That's where these other drugs that I mentioned at the end of my talk come in. The scar tissue inhibitors, the belumosudil, the pirfenidone, Jakafi, some of these other drugs. That's where we start using those. If the question means that a patient was on steroids and their body just got so weak, including their chest muscles, then I have to admit, getting down off steroids is key, but also exercise is key, nutrition is key. People always ask me what are the best foods to take if I have GVH. That's a tough answer. I'll give you a few, though, as patients that we see as physicians. One, keep your vitamin D levels up. Vitamin D doesn't just help bones, but it also helps as an anti-inflammatory agent. Two, don't laugh when I tell you this, dark berries. Cherries, blueberries, blackberries, raspberries, anything that's a dark berry has a lot of antioxidants in it and will help to repair tissue. So if the fact is that the steroid myopathy means that you've been on steroids and the lungs are now weak, the chest wall, then nutrition, exercise, get off the steroids. If it's that you've been on steroids for lung GVH and now your body is so weak that you just got to get off the steroids, there's fortunately a lot of other drugs that treat the GVH of the lungs now.
Okay, thank you. Great. I have another one here. A woman is writing in that she is starting to get some symptoms that we've been discussing today, and she's 6 years out. She's wondering, is it possible for late chronic graft-versus-host, like 6 years later, to just be developing symptoms?
Pretty rare, but it can happen. In my experience with chronic graft-versus-host disease that occurs that late, is that go back to the fire analogy. It's generally a really low-level simmering fire that oftentimes doesn't flare up to be as major a fire as we sometimes see in GVH that occurs earlier after transplant. So the answer is yes. It can occur this far out. It's a little atypical, but it can. The key is to start treating it aggressively now. I do feel that these later onset chronic GVHs oftentimes they may brew and simmer like this for a long time, and if you can get on top of it early, you have a good chance for turning them around.
Okay, perfect. Thank you. Another person writes here how to overcome the side effects of steroids. And this one I'd like to hear from you, doctor, but I'd also like to hear from Becky because it sounds like, Becky, you've had a lot of experience with steroids. But we'll start with you first, doctor.
Yeah. No, again, these are incredible questions. Obviously, patients out there are feeling the pain of being on steroids. When I first started as a transplant physician in the 1990s at the University of Michigan, steroids were it. We didn't have any other options. Now we've got a number of options. Some I've mentioned during the talk today. I feel strongly that steroids can be used to jumpstart the GVH treatment, but patients should get down and off steroids as quickly as possible. So, to prevent long-term steroid effects, prevent the use of long-term steroids. Start adding second-line agents. We're now starting to move some of these second-line agents, the Jakafis, the belumosudil, which goes by the trade name of Rezurock, pirfenidone. We're starting to move these things up much earlier, ibrutinib, earlier in a patient's chronic GVH course, in part to get them down and off steroids much earlier. And now we've got all these agents that we can use to supplant steroids. So I would say that's the first thing is to start looking at second-line treatments to get you off steroids quicker. I'll be curious to see what Becky has to say in terms of how she handled the steroid effect. I will say this, I showed the slides on exercise. Keeping a strong core tone is really good, yoga in particular. The muscles that steroids really weaken are your central core muscles, your hips and your lower back, things like that. So keeping a good core strength through any exercise that you can do through that, and I mentioned yoga too, is key. Bike riding is key. You may not realize it when you're bike riding, but your hip flexors are being used all the time as you pump the bike. So keeping muscle tone as strong as possible when you're on steroids is key, and it's the central muscle tone. So, I don't know, Becky, if you have thoughts too.
Becky?
Sorry, I was on mute. So okay, perfect. I have experienced steroids, unfortunately, often in my past 32 years. But as Dr. Yanik said, in the very beginnings in the 1990s, we didn't have a lot of other options. So steroids were obviously given and given at very high doses, where today we don't give those maybe necessarily that high of a dose as we used to in the past. But, day-to-day side effects of steroids will obviously depend on how much of a dose is given, but they are not fun. As you saw in some of my pictures, many people will experience the very swollen body. And unfortunately, it's just a body image issue that you will kind of have to realize is happening and then be hopeful, as in the slides that you saw, that you will go hopefully back to your original state. But in the meantime, you will deal with the swollenness and feeling just your body, when it feels swollen, it obviously doesn't feel good, and that brings up its own issues. And sometimes with the dosing of steroids, you may become temporarily or permanently a diabetic and have to be, chasing after your blood sugars and making sure you're eating accordingly to try to keep your blood sugars down. So that's unfortunately one of the side effects that you just have to be diligent about. You feel sometimes like you're crazy, and so just make sure your family knows around you that you're taking medications, and to give you a little extra grace, as you may not feel like your normal self. You may be short-tempered, and you have to give yourself the grace, but then you have to ask others for that grace as well. And then, you have to have a back mindset that there's a purpose for why you're going through that, why you're on that, and realizing that's currently your best option to get things controlled. And as Dr. Yanik mentioned, we have so many other options now. Like as I was tapering off in the last 2 years, we had already started. He mentioned the medication belimosadil, which is one of the newer medications. As I was getting lower on a dose, we put that into play so I could successfully taper off. So thankful we do have better options these days, but sometimes steroids is still required to get things controlled. There are and can be long-term side effects as well, besides the day-to-day side effects while you're on it. I have needed to have a knee replacement because it's just one of those things that comes with steroids on a long-term basis that it could affect your joint. So there are lots of things with steroids, and the transplant physicians and nurse practitioners of the day are looking at that. They've seen the studies, they see the history and the research that's done, and they're going to get you off of steroids as quickly as they can, but want to be successful. So I hope that answered some of that question.
Becky, can I ask you something, Dr. Yanik, obviously?
Yes, sir.
Just from your personal experience, and I'm about to take on my own profession, that transplant physicians are often ill-equipped to manage these late effects, the long-term care that patients need. And I don't feel that we do as good a job interfacing with a patient's primary care physician, with their internist, people that are much more in tune to the new therapies for blood pressure management, because you get hypertension on steroids is rampant, with the diabetes that you mentioned from the steroids, for keeping up bone strength. And, we focus on transplant, and sometimes I just don't feel that we serve our patient as well. I think everybody who's listening to this, think about, has your transplant physician become your primary care giver as a physician? Because sometimes we're ill-equipped to serve that role. And it really behooves us to have a good partnership with your primary care physician, who are in a much better position to handle some of these things. So the reason I said, Becky, can I have you answer this? What kind of interaction have you had with your own primary care physician? Have they been part of your care? has your transplant team managing all of these more long-term complications, or how is that working with you?
Sure. So yes, for my case scenarios particularly, I live very close to the Moffitt Cancer Center, and because I've had very little, excuse me, really I only had a 6-month break between my acute GVHD and my chronic, and it's continued to be an issue. I still have my primary care is done through my transplant team because I had so many complications. So I can't speak for the average person. I do know as a transplant nurse coordinator, when we sent our patients back to their primary care physician, we would send them the list of graft versus host disease symptoms. We would make sure that they were aware of what medications they were on, what their risk factors were, and then we try to educate and empower our patients to say what I just said earlier. If you have any new symptoms, call us. Then we'll tell you whether to see your primary care physician or come back to the transplant center. Any new medications that your physician, your primary care would like to add, please call us to make sure that it's not contradictory to something else that we've got you on.
Thanks, Becky. I do feel personally that we, the transplant physicians, don't do as good a job as we should educating our primary care physicians or internists. Maybe that's something that MBMT Link can actually work with. I know Peggy's group and Jennifer, you spend a lot of time educating patients. Maybe we should have an arm that we educate the ultimate long-term caregivers too, in terms of those physicians. So.
And if the patient has the opportunity to be at a survivorship clinic at like an NCI center or a large center, the patient, again, empowering the patient to also speak for themselves and to maybe get into that survivorship clinic so they have a better watch as well.
Excellent point, Becky. Correct.
Excellent conversation and excellent point. I'd like to bring Lauren in on that for a comment too. How is that handled at Memorial Sloan Kettering?
I don't think that I can speak exactly to that here at MSK just because of my setting on the inpatient side. But I do think that in just hearing Dr. Yanik speak and how important it is just to have that interdisciplinary team and to have that communication between providers, whether that's in the community or within one clinical setting or the transplant center itself. But I also really want to echo what Becky said, which is just advocating for yourself, which, we don't want to have to ask people to do that, but I think it's one of the most necessary pieces of this because, the teams, whether that is, a primary care physician, an oncologist, or a transplant specialist, they can't know about what you're experiencing unless, you tell them that. And what I always encourage my patients and caregivers to do is to just tell the doctor about any little symptom that you have, things that you might think might be trivial or, may not matter so much in the long run, but I think it's important that the teams know exactly what the patients are experiencing so that they can address it when it's possible, or to keep tabs on things to see how they evolve over time, and to kind of determine whether, greater follow-up is needed just as we're navigating some of these symptoms. And I think, too, in speaking to the role of the caregiver in this, I see a lot of the time that the caregiver is truly the one who notices some of these changes, especially so I think when they're kind of external. So if there's any, indication of skin GVHD, or if there's just a notice of changes in like functionality or ability. And so I think that, it's very important, I think, for both sides of these, for the medical providers and for the patients and caregivers to meet each other halfway, and just to make sure that they are, there is that constant communication and that the teams know exactly what's happening for the patient and for the caregiver to speak to that when they can.
Thank you, Lauren. I'm going to put my social work hat on a moment too and point out a few resources for people today. If you are not aware, there's a wonderful collaboration of GVHD organizations that work together to make sure that all of this great information is available for people. It is called the GVHD Alliance. If you go to gvhdalliance.org, you can find videos and printouts and basically anything you would want to know about GVHD. If you are in an area that maybe you don't have a lot of great resources, even be able to provide some of those things to your primary to show them your concerns. I also want to point out BMT InfoNet. They have something on their website where they can tell you where certain specialists are in your state if you're facing an issue. If you're in a rural area and there's not a lot of doctors that maybe fully understand this, you might have to travel a little bit to maybe one of the more populated areas. But they have a search engine where you can see what doctors specialize in GVHD and just all kinds of specialties in your state. I also want to point out, just with our steroid conversation, we did do a lunch and learn a while back. If you go to mbmtlink.org, you can download, we had a presentation about the love-hate relationship with steroids. And so I would highly recommend that one as well. So anyway, a few resources for you all out there. And I also want to get back to some of our other questions. And one comment here, which I just think I echo for everybody on this call. Dr. Yanik is wonderful. He's such a blessing to lung GVHD patients as he does incredible work. I thank him so much for his dedication to this terrible disease, and I couldn't agree more. What about, there was one person on here, and I think Becky and Dr. Yanik, you both kind of answered this, but they might like to hear a little more about it. You know, as far as chronic graft versus host disease sufferers of a certain age, this person's over 70s, sometimes it's difficult to tell apart symptoms of the disease from the natural aging process. I've had many false alarms and experienced that can't be tied directly or unambiguously to the disease, but nonetheless contribute to the overall situation. What are your thoughts on natural aging versus graft versus host disease? And maybe we'll start with Dr. Yanik. And Becky, I'd also like you to chime in again on this one too.
Sure.
But so Jen, by the way, I've given a lot of talks over years. These are some of the best questions I've ever heard. In terms of this one, I have one really concrete thought. As we age, for all of us on this call that are getting older, one thing you'll notice is that secretions start drying out. Our skin gets drier, our eyes get drier, our mouth gets drier. That's why you get more cavities as you age. You don't make as much saliva. Saliva has a lot of protective antibodies in it. Women will notice more dryness in other areas too. But overall, everything starts drying out as we age. And now you throw on chronic graft versus host disease, which is clinically manifested by tear ducts dry up, saliva dries up, skin dries up. So it's compounding itself. So I appreciate the question from the individual, because it really is. As we age, the manifestations, the dryness that you get in all organs, in all sites with chronic GVH, is doubly manifested by the normal aging dryness that we get. So I do feel that it's harder for individuals 60s, 70s, even 80s who get chronic GVHD to separate the symptoms apart. One thing that doesn't happen though is the lung GVH. We can pick up GVH of the lungs in that pulmonary function test and differentiate that from aging. And there's a few ways that we do that. So the lungs, we can tell chronic GVH from aging. But I will admit some of the other manifestations are difficult to tell because everything just starts drying up as we age normally. So good, unbelievable question.
Yeah, good one.
I know we have a lot of probably different age entities on this call, and I can tell you, as starting very young with the transplant process, I've actually been in long-term follow-up studies through St. Jude, and depending on your therapies that you receive, a normal patient, a younger patient who has received the kind of therapies that it takes to get to transplant, that a lot of us are aging prematurely even. So you're already 70 and you're feeling those symptoms, but somebody who's 50 may be feeling the symptoms of somebody who's in their 60s or 70s if they've experienced the transplant. But as far as the chronic GVHD goes, as Dr. Yanik mentioned, especially the sickest symptoms, which means the dryness of the eyes and the skin, and for females, the vaginal openings and structures, that could possibly just be a part of aging, depending on your age, but also a chronic GVHD. But for any symptoms that are quote unquote topical, we would always, your physician would always try and do a topical approach instead of a systemic, meaning doing medications, because medications also have their own side effects and can even reduce your immune system. And when you're already aged, you don't want to necessarily put more immune suppression on there. So if there's any topical solutions, and even if it's graft versus host disease, you would want to try those routes first. But it is going to be harder for somebody who's already of a more mature age to differentiate between. But definitely, still bring it to your physician's attention. If it was very significant, of course they could do skin biopsies and different things like that to rule out whether it was truly a GVHD phenomenon or just normal dryness.
Becky,
Thank you.
I want to give a shout out to Warren Center. Every April or every other April, Sloan Kettering, where Lauren comes from, holds a conference on graft versus host disease and transplant complications. I could probably get to Jennifer and Peggy the link for patients just to attend. One of the speakers this past year came from the University of Minnesota that spoke at Sloan Kettering. She talked about what's called cell senescence. And senescence refers to, in essence, the aging process. And she was speaking about her research was on what causes premature aging, not in transplant patients, but just in all of us. And then she started studying transplant patients. And she found that those that had graft versus host disease were getting the same process that she was seeing, this cell senescence of normal aging, but at a much more rapid rate. And that really was sobering to me to think about the fact, this whole notion of cell senescence, that as I'm this whole last hour and a half, some of my cells are living and dying and aging, but that whole process appears to be speeded up in her research in patients with graft versus host disease. The beauty of it is she's identified key proteins that trigger this, quote, cell senescence. Once we know the process and what's working, or what's causing the process, then we can start identifying treatments for it. For me, it's one of the most impactful talks that I ever heard, because it talked about how to slow down this tissue injury and tissue breakdown that all of you listening to this may ultimately face.
Very interesting.
Yeah.
Absolutely. I'd love to see that link and share it.
Yeah. Okay.
We have another question here. The doctor mentioned the benefit of exercise in a patient that bikes 30 miles per day. I'm imagining that might have sounded a little overwhelming to some. Is there any insight on how much is needed to be beneficial? Does it help more forms of GVHD other than the lungs? And how much exercise/intensity? So anything I think you can elaborate on.
Yeah, exactly. No, I got a lot of thoughts on this. T, again, his first initial is T. I myself, if I ever had to write my memoirs, I'd write a chapter on T. Just somebody who faced the adversity he faced and is riding 30 miles a day. No, I don't expect everybody listening to this to be able to ride 30 miles a day. I mean, his willpower to do this is unparalleled. So what should people be doing? There's two forms of exercise. One, there's exercise that's low and steady, meaning going out and walking a mile, 2 miles at a regular pace. That is a real key and a real help. It's even better if you can do a mile, 2 miles, and increase your heart rate. The ability to exercise for 20 minutes a day, every 3 days a week, at least in that range, where you get some sustained increase in your heart rate, that really helps to build that, I believe, that DLCO as THAB. You're maximizing you're really strengthening your blood vessels so that air can get across the lungs into the blood vessels. So no, I don't. Even by the way, I don't ride a bike 30 miles a day. Probably he's probably one in 10,000 people who do, maybe 100,000. So I can't expect any of you to do it. But what would be good is if you could walk 1-2 miles even a day, several days a week, keeping that core tone strong, and at some point during that, get at least 20 minutes in where you're really actually increasing your heart rate. Now you're going to tone your blood vessels. The long, slow, steady will tone your muscles. The 20 minutes of higher speed will tone your blood vessels. So long, slow, steady, with periods of any exercise where you just pick up your walking speed for half a mile, for example. So that's what I'd recommend.
You learn something every day. Thank you so much. We also have some questions about GI GVHD. I know our focus is mainly with the lung, but do you have any thoughts to offer about GI issues? And then same thing, Becky, if you have anything to share. As well as you, Lauren, if you have thoughts in the background too, we could do a 1, 2, 3.
Yeah, I'll keep it. I'll go to the scientific end in terms of just what people are looking at research-wise, and then I'll turn over to Becky and Lauren. What we're seeing in patients that have graft-versus-host-disease of the intestines is that we call it their gut microbiome, which is their normal bacteria, their normal flora, as we say, of their intestines, is incredibly altered. Instead of having a lawn of healthy grass, you've got a lawn with weeds everywhere. You got this microbiome that's just totally abnormal. By the way, patients who have abnormal intestinal microbiome are typically the same ones who have abnormal respiratory or lung microbiome and get the lung GVH. We're seeing that altered microbiome in the gut directly increases the impact, or it increases the frequency and severity of GVH, not only in the gut, but in other places like the lungs. So what do I tell patients? Anything you can do to optimize your gut microbiome will help your gut GVH. There's two types of biotics. There's prebiotics and probiotics. Probiotics are things like yogurt. Prebiotics they have these non-absorbable starches. We use one at our center called Bob's Red Mill Starch. It's a probiotic that increases what's called butyrate, and butyrate is what strengthens the gut microbiome. So for patients with gut GVH, anything you can do to strengthen get your microbiome healthy actually will improve your GVH, and potentially not only in the gut but in other places.
So I would echo what he said as far as the microbiome. Obviously, so again, when your gut is irritated, those donor T cells look at it, and their job is to fix what's broken. And then they get there, and then they realize, oh, this tissue doesn't look like me, and it attacks it. So of course, there's got to be this underlying control of your donor's T cells. But another way to keep the T cells from recognizing that abnormal tissue is to, as you said, try on your side on the things that you can control to have that healthy gut. But still, ultimately, if that is happening, then of course, there's topical steroids, a couple of different ones that are used specifically for the gut, and then the other immune suppression medications typically given with graft versus host disease. But he's absolutely right. Like, the best you can get your gut lining and bacteria to be, then hopefully that will contribute to less issues of graft versus host disease of the gut. But at the same time, you need to make sure that you're speaking with a nutritionist to make sure you're getting the calories and support depending on how significant your diarrhea is. And then you need to also be speaking with your physician to make sure that you don't have an infectious disease process going on in your gut. Rule that out, and then use these proper medications and even possibly supplementing. Again, please ask your physician on all these things, but supplements on maybe something like Imodium or Lamodal, things that would help slow that down so you can get caught up and have a good nutritional level.
Becky, I may use your analogy of the T cells when you started. It's probably going to incorporate it into my talks with patients because it actually was perfect. It really was. We run into a lot of C. diff, Clostridium difficile infections in patients with chronic GVH. And the reason they get the C. diff is that once you wear down your normal microbiome, the C. diff are like weeds, and that's what takes its place. And that's why patients get C. diff when they have chronic GVH. So.
Thank you for that. Lauren, did you have anything you wanted to add there? Any thoughts?
Not in that respect. I was going to echo some of what Becky had said as well. So I think Dr. Yanik and Becky did a good job answering that.
Okay, well then I'll ask you this one. We have someone who was talking about fatigue and how to cope with that. And again, we can do the 1, 2, 3 formula. You all have something to share. Lauren, what do you recommend to patients that have difficulty with fatigue? It looks like we might have had a technical issue with Lauren. How about you, Becky? What are some of your best tips for fatigue?
So definitely incorporate, know it's normal. Know sometimes it's going to be worse than it was the day before. Incorporate rest periods whenever you can. And then for GVHD patients specifically, you have to keep a balance. Like if you work yourself and you work really hard for a day, then realize that may be 2 steps backwards. For the next 2 days, you may just be not able to get off the couch. So try to keep a balance. Try to keep active, but not do too much because you will pay for it in the days to recover. So having a balance, realizing it's to some degree very normal to be experiencing fatigue. It's one of the symptoms of graft versus host disease, and then of course it's symptoms of treatment related to graft versus host disease.
Thank you. How about you, Dr. Yanik? When you hear that, I'm imagining you have some thoughts too.
Yes, Jen. I kind of view fatigue as in 2 ways. Mental fatigue, it's a long race that patients run, and it just mentally is wearisome. But then there's medical fatigue from tissues and organs being worn down. One in particular that we don't often think about that physicians need to is endocrine fatigue. So your hormone, your organs that produce various hormones over time can get fatigued. And this medical fatigue, I'll give you a quick example, can easily lead to mental fatigue. Here's one. Your thyroid gland. Patients with chronic GVHD, their thyroid gland over time, oftentimes starts just blowing down. The slower your thyroid gland is functioning, the more fatigued you're going to feel. Your adrenal glands. Adrenal glands are also another hormone-producing organ. They produce adrenaline or cortisol. It's easy for us as physicians to measure a thyroid blood test or cortisol adrenal blood test. And if it is, then we can give you a medication that can correct that. So I recognize that fatigue both has 2 components, the mental wear and tear fatigue and then the actual tissue injury fatigue. And make sure if you tell your physicians that you're just tired all the time, just say, hey, can we check my thyroid gland? Can we check my adrenal gland? And just make sure that they think about that. So, okay.
Okay. Well, thank you so much. I cannot believe we are already at 1:30. Time flies, and such an amazing presentation from all of you today. I just want to thank all of our speakers for being here today. I really have just loved this program. I also want to thank our sponsors, Pharmacyclics and Insight. And of course, just a reminder, everybody, that we will be sending out a survey. Also, we can try to get that link if possible from Dr. Yanik. And we also have some slides on our survivorship webinar, more on fatigue, that maybe we can send out as well. So we'll try to send you some goodies. Look in your email for them. But we thank you so much for being here. I also want to make everyone aware, too, we started to touch on nutrition today. We have a wonderful nutrition talk coming up next week on the 13th for our Lunch and Learn. So you could also go to our website and register for that if you want to hear more about nutrition. But thank you again, everyone, and I hope you all have a good day.
Thank you. Thank you. That does conclude today's teleconference and webcast. You may disconnect your line at this time and have a wonderful day. We thank you for your participation today.